Hello, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about the precancerous lesion in gynecology. So, what we want to discuss today, the cervical intraepithelial neoplasia, the endometrial hyperplasia, and the vulval intraepithelial neoplasia. Please look to this picture. We'll start with cervical intraepithelial neoplasia, what's called the CIN. At the left side of the picture is the normal epithelium with intact basement membrane. On the right side of the picture is the invasive cancer with the invasion of the basement membrane. In the middle of the picture there is CIN1, 2, and 3. CIN1 corresponding to the mild dysplasia. It's all the name. CIN2 is a moderate dysplasia. CIN3 is a severe dysplasia. CIN1, there is a typical cell in the deep third of the thickness of the epithelium, as you see here. This is the atypical cell. In CIN2, the atypical cell affecting the middle third of the epithelium. In CIN3, the atypical cells affecting the superficial third of the epithelium. Okay, so this is the difference between CIN1, CIN2, and CIN3. All of them intraepithelial lesion without invasion of the basement membrane, as you see here. So the definition of dysplasia and CIN is the presence of atypical cells affecting certain epithelial thickness without basement membrane invasion. Also, squamous intraepithelial lesion may be low grade or high grade in case of pap smear. What about carcinoma in situ? Whole thickness of the epithelium is replaced by atypical cells without basement membrane invasion. What are the risk factors? Human papillomavirus infection is the most important risk factor, especially type 16 and the type 18. Type 16 is the most carcinogenic and account for 60% of cervical cancer worldwide, while human papillomavirus 18 is the second most carcinogenic and account for 15% of cervical cancer. However, only a relatively small percentage of women with infection will develop severe CIN or invasive cervical cancer. Okay? And human papillomavirus has more than 100 types, but the most important types as regard which may cause CIN is human papillomavirus 16 and human papillomavirus 18. Human papillomavirus is a sexually transmitted disease. Risk factors such as smoking, immune-compromised state, or HIV infection likely lead to persistence of human papillomavirus infection and an increased risk for the development of CIN. Okay, what about the epidemiology? Human papillomavirus infection occur in sexually active women of any age, but it is more common in young women under the age of 30. Okay, the highest incidence is in women ages 20 to 24. And these young women are the most likely to clear the infection to undetectable levels in an average of 8 months. That's why if there is human papillomavirus above the age of 30, okay, this means persistent infection and warrant more aggressive follow-up to rule out cervical intraepithelial neoplasia. Cervical cancer incidence and mortality decreased, especially in developed countries, due to screening program using Pap test and the human papillomavirus testing. This screening program gives the advantage of preventing cervical cancer because it can detect the precancerous lesion CIN2 and 3. What about the pathology? By naked eye and by microscopic examination, by naked eye, non-specific and ranging from normally appearing cervix to highly suspicious cervix with ulceration or erosion. By microscopic examination, a TB affecting certain epithelial thickness without basement membrane invasion. And the classic microscopic description of human papillomavirus infection of cervical epithelial cells is coilocytosis, and this term refers to the appearance of perinuclear halo within the cell, along with enlarged and irregular nuclei that show evidence of mitosis. This is the grades of CIN. CIN1 is a low grade, CIN2 and 3 are high grade. And this is, as mentioned before, CIN1, 2, and 3, and the part of the epithelium affected. According to different methods of grading and interpretation, the old name of these lesions by WHO and the use of the old terminology normal for healthy skin, cervical epithelium, or human papillomavirus infection, or mild dysplasia, or moderate or severe dysplasia, or carcinoma in situ. While the cervical intraepithelial neoplasia system divided into normal human papillomavirus infection, CIN1, CIN2, CIN3. CIN1 related to mild dysplasia, CIN2 moderate dysplasia, CIN3 severe dysplasia. According to the BCD system and updated by WHO, there is certain categories like negative for intraepithelial lesion or malignancy, or low-grade squamous intraepithelial lesion, or high-grade squamous intraepithelial lesion. This is the most important. Then gray zone interpretation and atypical squamous cells, which divided into two categories: atypical squamous cells of undetermined significance and atypical squamous cell suspicious for high-grade squamous intraepithelial lesion. And this is important and should be taken seriously. What is the behavior of CIN? Most cases of low-grade CIN, which is CIN1, will regress with or without treatment, while high-grade CIN, like CIN2 and 3, can progress to invasive cancer within 10 to 15 years if untreated. And you should know that up to 30% of CIN3 can progress to invasive cancer. Diagnosis depends on the symptoms and signs and investigations. Symptoms may be asymptomatic in the majority of cases, or there may be contact bleeding or vaginal spotting or vaginal discharge. On examination, there may be non-specific signs ranging from normally appearing cervix to highly suspicious cervix with ulceration. Investigation including screening for cervical cancer by doing cervical cytology or Pap test or Pap smear testing, or testing for human papillomavirus, or both of them. In low resource countries, we may need to do visual inspection of the cervix with acetic acid test, and the aceto-white areas is considered suspicious, and biopsy or colposcopic examination of this area and the punch biopsy can be taken from this area. Visual inspection of the of the cervix with acetic acid is cheap, less expensive, can be done in the developing countries in wide range of people with very, very minimal cost. Okay? Colposcopy is beneficial in positive cases and for examination of the cervix and taking biopsy from suspicious lesions. What is the treatment? Let us start with CIN1. CIN1 can undergo observation and co-testing repeated in 1 year. So you ask the lady to come again after 1 year and do the test again, the PAP test again. If CIN1 is persistent after 2 years or progresses within that time, I mean go to be CIN2 or 3, treatment should be recommended. So either being persistent or progressing should be treated after 2 years. Okay? CIN2 or higher requires treatment. Treatment is also recommended when there is more than 1 degree of difference between PAP results and the biopsy results. So if you found difference between the PAP and the biopsy, okay, treatment is also recommended if there is more than 1 degree of difference. The usual treatment, either ablation or excision of the abnormal cells. As you see in this table, ablative procedure like laser ablation, like cryotherapy, like diathermic coagulation, but you should take care about that. If you are going to do ablation, the endocervical sampling should be negative and there are no glandular abnormality and the entire border of the lesion are visible. Okay, so not to miss any lesion. Excisional procedure like LEAP, which is abbreviation of loop electrosurgical excision procedure, or cold knife conization or laser conization. But one of the disadvantages of excisional procedure rather than bleeding or infection is long-standing side effect, which is cervical incompetence and preterm labor in next pregnancy. However, still this area there is a controversy about this problem as regards the incompetence of the cervix and the preterm labor. Okay, what about follow-up? Women treated for CIN2 or greater should have a PAP smear and human papillomavirus testing 12 and 24 months after the procedure. Okay, so after 1 year and 2 years, testing should be done. PAP test and the human papillomavirus testing. Okay, even with positive endocervical margin, when an excised specimen, the procedure is deemed 70 to 80% effective. What about if the margins are positive? And when should I repeat cytology? I should repeat cytology within 4 to 6 months, accompanied by endocervical curettage is very important. Okay, what about persistent or recurrent CIN2 or 3? What is the treatment? Treatment may be repeat excisional procedure like LEAP, like laser conization, like cold knife conization, or if the patient completed her family size and no desire for more children and she preferred to do hysterectomy, go on and do hysterectomy as a line of treatment. So either excisional procedure repeated or do hysterectomy. Let us go to the next precancerous lesion, which is endometrial hyperplasia. What is the definition of endometrial hyperplasia? Proliferative lesion of endometrial gland and to lesser extent endometrial stroma. Why it happened? Due to exposure to unopposed estrogen for a long time. I mean excess estrogen and the relative deficiency of progesterone. Endometrial hyperplasia is a precursor of endometrial cancer, which is one of the commonest gynecologic malignancies. exposure to excess estrogen may be endogenous, as in PCOS, polycystic ovarian syndrome, or ovarian tumor secreting estrogen like granulosa cell tumor, or exogenous like estrogen as a treatment in hormone replacement therapy in postmenopausal lady. What are the risk factors with endometrial hyperplasia? The age, nulliparity, obesity, genetic, diabetes mellitus, anovulatory cycle, PCOS, and the perimenopause age, ovarian tumor like granulosa cell tumor, hormone replacement therapy, specifically estrogen only therapy, immune suppression as in case of renal graft recipients, and infection, hereditary non-polyposis colorectal cancer or Lynch syndrome. The pathology of endometrial hyperplasia may be simple hyperplasia, complex hyperplasia, atypical hyperplasia, and this is the old classification. And the more recent classification by WHO in 2014 divide them only two categories: endometrial hyperplasia without atypia, endometrial hyperplasia with atypia, because atypia is the most important factor as regards the prognosis. And each one of them can be divided into simple and complex. Okay, but the old one is simple hyperplasia, complex hyperplasia, and atypical hyperplasia. What is the pathology in simple hyperplasia? Proliferation of postglandular stroma, but glandular and stromal ratio is normal. Glands are enlarged, irregular, with occasional pseudostratification and papillary budding of the epithelium into glandular lumen, and some gland may show cystic dilatation. There is no nuclear atypia. What about complex hyperplasia? The glandular proliferation is more than stromal growth, so glandular stromal ratio is increased, and this is noted by back-to-back appearance of the glands. Glands are enlarged, grossly irregular, with frequent pseudostratification and papillary budding of epithelium into glandular lumen. There are many mitotic figures, but no atypia. Atypical hyperplasia is very important and characterized by atypia and classified as simple or complex. Atypia means the presence of malignant criteria in tissue and is characterized by the bizarre shaped cell, the increased nuclear cytoplasmic ratio, apparent nucleoli, increased abnormal mitotic figure, hyperchromatosis, polymorphic second wave nuclear membrane. But as I mentioned before, the WHO updated this classification into two categories: hyperplasia without atypia and atypical hyperplasia or endometrioid intraepithelial neoplasia. The behavior of endometrial hyperplasia: in simple hyperplasia, the progression to adenocarcinoma is 1 to 2%, while in complex hyperplasia, the progression to adenocarcinoma is 8 to 10%. While in atypical hyperplasia, the progression to adenocarcinoma is 20 to 30%. That's why it is dangerous, typical hyperplasia, and carry the bad prognosis. Because in 30% it can progress to adenocarcinoma. And the time for progression of atypical hyperplasia to carcinoma is variable. To diagnose a case with endometrial hyperplasia, you should take a detailed history and do physical examination. Take care about the clinical documentation, which should include the history of the present illness, menstrual history and symptoms, duration of the cycle, flow, the passage of clots, intermenstrual bleeding, the postmenopausal bleeding, unscheduled bleeding, if woman is on HRT, the age of menarche, transition through the perimenopause, age of menopause should also be recorded. It is important to note the obstetric history and whether the patient wishes to conceive in the future. The symptoms in the form of abnormal uterine bleeding. This abnormal uterine bleeding may be in the form of heavy menstruation or irregular bleeding, intermenstrual bleeding, or unscheduled bleeding in patient on HRT, or postmenopausal bleeding in postmenopausal ladies. Okay? There may be lower abdominal cramp, there may be vaginal discharge, which may be foul smelling or blood stained. There may be symptoms of the underlying etiology. What about the signs? The uterus may be symmetrically enlarged. There may be signs of underlying etiology. There may be pelvic mass like ovarian tumor secreting estrogen, like granulosa salt tumor, and may be the cause of endometrial hyperplasia. Investigation, ultrasound, especially transvaginal ultrasound with high resolution, is the most important. It can detect the endometrial thickness and any irregularity of the endometrium. Also, endometrial biopsy, and endometrial biopsy could be through hysteroscopic guided biopsy or DNC and biopsy or suction curette endometrial sampling. About the transvaginal ultrasound and its role in measuring endometrial thickness, especially in postmenopausal lady with cutoff of 4 millimeter. So, endometrial thickness should be less than 4 millimeter because endometrial thickness in postmenopause is atrophied. Okay, so should be less than 4 millimeter. More than that needs a biopsy. Less than that, you may not need any biopsy because the possibility for recurrence of endometrial cancer is low, less than 1%, if it is less than 4 millimeter. Okay, so ultrasound detection of endometrial thickness is important, and any irregularity, any mass should be reported. Any pelvic mass, uterine or adnexal or ovarian mass like functioning ovarian tumor also should be reported. Differential diagnosis, we should differentiate each one of hyperplasia from the other. Also, we should differentiate hyperplasia from other benign conditions like proliferative and secretory endometrium, also from endometrial polyps, and from complex hyperplasia with atypia from grade 1 endometrial carcinoma. Treatment depends on the type of endometrial hyperplasia, the age of the patient, desire for fertility. And the method of treatment may be medical treatment or surgical treatment. Okay, let us go to the treatment and look to this table, please. Here is the age in reproductive age or in postmenopause age. And here is hyperplasia without atypia or atypical hyperplasia. Okay, so how to deal with the woman in reproductive age with hyperplasia without atypia? We can give her gestagen therapy for 6 months through oral gestagen for 6 months or intrauterine levonorgestrel releasing intrauterine system. Okay, like Mirena, releasing a small amount of progestogen every day, suppressing or antagonizing the effect of estrogen on endometrium. Okay, if the treatment succeed by biopsy after 6 months, well and good. If not, or you consider it failed, so you should do hysterectomy. Okay, but if patient desiring fertility, you should encourage pregnancy. Okay, so what about the postmenopause lady with endometrial hyperplasia without atypia? I can give her gestagen therapy for 6 months, and if hormonal treatment failed, we are going to do hysterectomy. What about atypical hyperplasia and the woman in reproductive age? If patient completed her family, we should do hysterectomy. But if the patient not completed her family and desire for fertility, encourage her to become pregnant, and after completing her family, do the test, the endometrial biopsy again, endometrial sampling. If still atypical hyperplasia, you can do hysterectomy after she completed her family size and they need no more children. What if a postmenopausal lady with atypical hyperplasia? The clear indication for management here and the best method of treatment is hysterectomy. What about treatment duration and the follow-up? You should give treatment for 6 months to induce the regression of hyperplasia. Okay? Endometrial surveillance with office endometrial biopsy is recommended at 6 months interval and before discharging the patient as a free from the problem, 2 consecutive 6 monthly negative biopsies. So you should take one biopsy after 6 months and another biopsy after 6 months, and both of them negative, so the patient is cured. What about if the woman has a body mass index more than 35? Is it dangerous? Yes. Overweight or obesity, the fat is a source of estrogen. As all of us know, androstenedione is changed into estradiol, and that's why obesity is a risk factor for endometrial hyperplasia. Okay? So, if body mass more than 35 and the woman were treated with oral progestogen, she is at higher risk of relapse, and she should be advised for annual follow-up. Also, all women should be advised for follow-up if they experience the symptoms of abnormal uterine bleeding. Let us go to the vulval intraepithelial neoplasia, which is defined as the presence of atypical cells inside the epidermis of vulval skin without basement membrane invasion. Okay, it is a precancerous condition, may go to become squamous cell carcinoma, and it takes time up to 10 years. This vulvar intraepithelial neoplasia is an increasingly common problem, particularly among women in their 40s. Incidence increased over the last decade in Western Hemisphere due to widespread infection by human papillomavirus. Vulval intraepithelial neoplasia is higher in white women. The usual type is more common at younger age, while the differentiated type occur more prevalently in older women. So I have two types of VIN, usual or undifferentiated. Okay, and the other type is differentiated. Okay, usual one, take the abbreviation of UVIN. Differentiated one, take the abbreviation DVIN. Okay, what is the difference between them? The usual VIN affect women under the age of 50. Okay, and is thought to be caused by human papillomavirus infection. What is the most common subtypes of human papillomavirus? 16, 18, and 33. Okay. What about differentiated VIN? This is the rare type, usually affecting women at older age, over 60. Okay? And it is associated with chronic inflammation of the skin of the vulva, like lichen sclerosis or lichen planus. Okay? So, I have two categories of the patient in VIN. UVIN, the usual, and DVIN, the differentiated vulval intraepithelial neoplasia. UVIN affecting younger women below the age of 50 and related to human papillomavirus infection, especially type 16, 18, and 33. While the DVIN, the differentiated VIN, affecting women above 60. Okay, and related to skin lesion, chronic skin inflammation of the vulva, like lichen sclerosis and lichen planus. Okay. What are other risk factors for VIN? Multiple sexual partners, cigarette smoking, immune compromised patients, autoimmune disease, organ transplant, HIV infection. By naked eye, picture ranging from normal appearing vulva to highly suspicious vulva with raised sharply demarcated recentous pigmented lesions. By microscopic examination, the histologic feature necessary for diagnosis of VIN is the proliferation of atypical basal cell. The 5 criteria for atypia are as follows: basal layer involvement, enlarged nuclei, hyperchromasia, oleomorphic cells, and increased number of mitotic figure. In addition to atypia, UVIN and DVIN have distinctive feature and can be differentiated by immunohistochemistry. This is a grade, the old classification of VIN 1, 2, 3, like that of CIN, as I mentioned before. VIN may be asymptomatic or associated with pruritus. UVIN and DVIN are clinically different. Okay? Tell me more about that. UVIN lesions are commonly multifocal and elevated, seen around the introitus and on labia majora, while DVIN lesions demonstrate poorly demarcated pink or white plaques that often associated with lichen sclerosis or lichen planus that is refractory to medical therapy. Take care when you are examining the vulva, okay, and you found any lesion, detect the site, the number, the size, the shape, the color, and the thickness of the lesion. Okay, is there any routine screening test for VIN like that of CIN? The answer is no, no routine screening test. However, abnormal cytology or positive high-risk human papillomavirus test used in cervical cancer screening warrants an independent visual assessment of the vulva. Okay, so if you are doing screening for cervical cancer for CIN and you found positive human papillomavirus testing or BAP test CIN 1 or 2 or 3, please inspect the vulva. Do inspection of the vulva and examine the vulva very well. Okay? Can I do acetic acid test in the vulva like that of CIN for cervical screening? No, it is not recommended for diagnosis because the white in the color of observed lesion is not specific to vulvar intraepithelial neoplasia. Biopsy is very important. Any observed vulvar lesion requires a biopsy to define treatment appropriately. What is important also is the immunohistochemistry marker, which can be used to differentiate between usual VIN and differentiated VIN. B53 positive and the B16 negative support the differentiated VIN, while the converse support the usual VIN. What about the treatment of vulval intraepithelial neoplasia? The ideal treatment involves the complete destruction of the lesion, which will improve the symptom and preserve vulvar function. What are the options in treatment? Medical and surgical and expectant and preventive. We can consider human papilloma virus vaccination as a preventive management because it protects from human papilloma virus, which has a risk in case of vulvar intraepithelial neoplasia. Which type? The usual type, which occur in younger age. Okay? Let us see the treatment of UVIN and DVIN. In UVIN, the usual VIN, we can use either cold knife surgery and the loop electrosurgical excision procedure and this is considered treatment of choice. Okay, but take care that the recommendation are 5 millimeter peripheral margin and the 4 millimeter deep margin. Okay, an alternative treatment is CO2 laser ablation, but vaporization of the diseased tissue precludes a pathologic space. Okay, what about differentiated VIN? Treatment of this lesion should include surgical excision with a scalpel, leap, or laser. Wide local excision is preferable as initial treatment. DVIN is associated with lichen sclerosis and invasive disease such as squamous cell carcinoma of the vulva. Recurrence rate for DVIN are much higher than UVIN. So DVIN is more dangerous, and the recurrence rate is higher than UVIN. And we can differentiate both, as I mentioned before, by immunohistochemistry. There are no currently approved medication for the treatment of vulvar intraepithelial neoplasia. However, many drugs have been attempted to avoid surgery, like cidofovir, which is antiviral, promote apoptosis of human papillomavirus infected cells. Another line of treatment for vulvar intraepithelial neoplasia is the photodynamic therapy. Is considered an option in conjunction with non-thermal light to generate oxygen-induced cellular death. What about the prognosis? The prognosis of biopsy-confirmed vulvar intraepithelial neoplasia that receive immediate treatment is uniformly good. So, if you give the patient the proper treatment, the prognosis is good. There is rarely progression to invasive cancer unless treatment is declined or markedly delayed. So please don't lose time while you are saying this is just inflammation, this is can be treated with anti-inflammatory or other lines of treatment and so on, and you neglecting the thinking about vulval intraepithelial neoplasia. Because if you diagnose the case by biopsy and you give the patient the proper treatment by excisional procedure or ablation, the prognosis will be good. Thank you. This is my or three books published on Amazon, textbook of obstetrics, textbook of gynecology, and the contraception handbook. You can go to Amazon to see these books. Okay, thank you.